Thank you, Chikun. Okay, I can also talk with Malaysian accent. Can lah, can lah. Okay, so as Chikun says, I trained in England, and I trained to be both a clinical doctor and a public health practitioner in the NHS. I also spent 10 years in South Africa. And firstly, it's very nice to be back in Malaysia after many years. I've been back for about 4 years now. I was asked to talk about the NHS, the National Health Service of England. And I don't know how many of you are familiar with the NHS, the term. For many years, for many decades, people all across the world talked about the NHS as this gold standard for country health systems, and a lot of countries looked up to it, a lot of people admired it, and a lot of countries tried to copy it. So I think it's useful to talk about the NHS and to think about how is this relevant to Malaysia. But before I do that, yeah, okay, got it. Okay, before I talk about the NHS, I just want to go over a couple of points, maybe a little bit overlapping what Debbie talked about, in terms of making some generic points about health systems. I think when Debbie talked about health systems earlier, she talked mainly about the function of health systems in terms of delivering personal and non-personal health services, clinical services and public health services and programs. But I want to just also talk about the way health systems provide a variety of other functions, yeah? So for example, as I put here in the second bullet, health systems also play a cultural role in society, yeah? The way in which health systems operate, particularly in terms of how we manage and the experience of birth, aging, and dying, is a cultural function of health systems. Yeah. So, for example, we see how many people in many countries now die in hospitals. They don't die at home. The way in which childbirth is practiced, very medicalized in many countries. In countries like Brazil, almost half of all childbirths now occur through cesarean section. It changes completely the cultural experience of birth. So there's a cultural function that health systems provide in society. There's also a social protection function. The way health systems are designed will have a huge impact on the financial consequences that people experience when they fall ill or they become injured or disabled. In the United States, the biggest cause of bankruptcy, of household bankruptcy, is the cost of healthcare. Yeah, so there's a function of health systems to prevent people from becoming impoverished as a result of falling ill or having an accident or being born with a disability. Health systems also play a societal function in terms of reflecting social values and shaping the relationships between different elements of a society. They help shape and reflect the role and responsibility that governments have for their citizens, for their people. It also shapes the relationship between old people and young people, between people who are born with a disease and people who are lucky enough not to be born with a disease, between those who are young and healthy and those who are sick and elderly. Yeah. How a health system is designed, how it's financed, will shape these relationships within society between different groups of people, between citizens and the government, the idea about the relationship between the market and the state. So health systems play a really important social and political role in society as well. You look at the difference between healthcare in Kuala Lumpur and Sarawak, and you see the way in which health systems shape and reflect the relationship between rural Sarawak and urban Kuala Lumpur. But finally, also to recognize that health systems play an important economic function. Debbie talked about thinking of healthcare as an investment. A healthy population is a more productive population, so it has this economic function. And then, of course, healthcare systems are increasingly also economic sectors or business sectors, which provide a source of income and wealth for people. Yeah. It's income in the form of salaries and wages for doctors and nurses, but it's also a source increasingly of profit for shareholders and for people who own companies. Yeah. So health systems play multiple functions. It's not just about the delivery of healthcare or the delivery of public health programs. When we think about health systems, we should be thinking about them holistically, how they play this wider set of functions in society. Okay, let me pause there and see if there are any comments or questions. We can make this interactive, so it's not just me talking. Any comments?
Sorry, Raymond here. So I also had the chance to work in NHS for a couple of years and understand how it works, and also Singapore as well for about close to 10 years. This is a brilliant idea of these functions, but how, in your opinion, how are you going to incorporate and integrate all this, health system in a very holistic way that actually benefits all the stakeholders within the ecosystem?
Perfect, because that leads into my next slide. So my next slide is making this very basic point that all of the debates that we hear about, capitation or block funding or fee-for-service funding, social health insurance or tax-based financing, these are very technical debates. But fundamentally, I would argue that all policy debates and disagreements are fundamentally about the question of who pays and who benefits. Yeah. And when we talk about this tension, who pays and who benefits, what we're talking about are competing interests. Yeah. There are different groups within society, different groups within a health system that want to benefit and want to pay as little as possible for the payment of healthcare. Okay? So a lot of policy debates are really political debates about who pays and who benefits. There are obviously technical debates and discussions to be had, but fundamentally, when we're talking about a national health system, there are always trade-offs about who will pay and who will benefit. Now, when we talk about benefit, what do we mean by benefit? What kind of benefits are we talking about? Anyone? We're talking about health benefits. Is that right? Yeah, so we're talking about how we pay for a health system in order to maximize health. Yeah, in order to ensure that people will benefit in terms of improved health. But there's another set of benefits that we have to think about as well. What are they? Okay, productivity, so these are wider economic benefits. What else? Money. Yeah. So we have to be thinking about who benefits financially from the way health systems are organized. the way health systems are funded. Yeah. Yeah. So there are also social benefits in terms of, for example, some people will derive social and political benefit from making decisions about healthcare financing, for example. We talked earlier about the way in which hospitals are always glamorized. Yeah, that the doctor that saves one life through a heroic 6-hour surgery will get a lot of social capital and a lot of praise, but your underpaid community health worker who is helping, poor communities to vaccinate their children will be ignored, will never be recognized, will never get the same kind of praise as that one heroic surgeon saving one life through a 6-hour operation. So there are all kinds of benefits that we can be thinking about. But all of this is really to highlight the point that many of these debates and disagreements about healthcare policy are, in a sense, political with a small p. Yeah, it's about competing interests amongst different segments of society. But I want to come back to the issue of money. Yeah, when there's a famous Canadian health economist called Robert Evans, and he talks about understanding health policy reform in terms of these 3 boxes. If you want to understand the debates about health policy reform, you have to think about following the money. Yeah. Now, when you think about health financing, the first box is about revenue, R. Where does money come from? The second box is you raise the money, but then you want to spend the money. Expenditure. What is money spent on? And then the third box is who gets the money after the expenditure? Income, I. R should always equal E, which must equal I. Yeah? The money we raise is spent. The money that we spend is then ends up in someone's pocket. Okay? Let's think about unpacking these boxes. Where does money come from? Taxes is one source of money. We also know in Malaysia, a large amount, as Chee Kun showed earlier, comes from out-of-pocket payments. There's also insurance premiums that people pay for insurance. Sometimes it's the individual who pays, sometimes the employer will pay for that. In very poor countries, this is not Malaysia, you also get external aid coming into countries. And there's also finance capital. Yeah, private investors are putting money into the healthcare system. So that's where the money comes from. What is money spent on? We can spend money on services and programs, bricks and mortar for building clinics and hospitals, IT systems, transport, pharmaceuticals. Yeah, so healthcare expenditure is on all kinds of different items. Who gets the money? In most health systems, a large amount of money end up as wages, salaries for health workers. Increasingly, we're seeing in health systems that become more and more complex. There are not just health workers who have to be paid, but there are managers, there are accountants, there are data officers, there are lawyers, especially in countries where there's a lot of litigation in the health system. There are, in healthcare systems which are very privatized, if you go to America, for example, you'll see all over the place that there are advertisements for healthcare. So this is, again, healthcare expenditure, but it ends up being expenditure that is earned as money by advertisers. You build hospitals, the money to build the hospital ends up as income for engineers and builders and contractors. And when you have finance capital coming into a health system, private investors, they expect to see money returning in the form of profits. Yeah. So this is money that is earned by shareholders. So when you think about the equation, revenue must equal expenditure, which must equal income, you can see that if money is going to shareholders, that money from healthcare expenditure has to be taken away from the other people that also earn money from healthcare expenditure. Yeah. If more money is going to doctors, that may mean less money for nurses, less money for allied healthcare workers. If more money is going to hospitals, that must mean less money for the people working in primary care. If we're building and spending large amounts of money on IT systems for healthcare, paying money to Microsoft, paying money to Meta, that means there is less money to be spent on the salaries of doctors and nurses. So there's always competition, both in terms of what we spend money on, but also ultimately on who will earn income from that money. Now, I say this because in India right now, amongst the new billionaires that have been created in India over the last 5 years, the new billionaires, newly minted billionaires, the biggest number of those newly minted billionaires has come from people working in the healthcare sector. Yeah. India. And obviously, if you go to a place like the United States, there are many billionaires who have made their billions from healthcare expenditure. So, you know, we need to be thinking about healthcare systems in this way, not just talking about expenditure, but also thinking about income. Okay, let me pause there. Any questions? Yeah.
Sorry, I'm Sheridan from Malaysia Kini. I had assumed that in one of these boxes, or at least the third box, we would have the patients. As in, where does the money go?
Yeah, patients don't earn money.
But they're spent on?
They
What?
pay. Is that what you're saying? Do patients earn money?
Oh no, I mean like because where do the patients fit in these boxes?
This is about the flow of money. So patients fit in, you know, everywhere. Patients in the first box, patients sometimes have to pay out-of-pocket expenses, or they're paying for private insurance. Patients fit into the second box because your expenditure pattern will determine what services are available to patients. And in terms of who gets the money, I mean, yeah, patients don't really fit into the third box. They tend not to earn from healthcare expenditure. Yeah. Yeah, subsidies is expenditure. Yeah, you're choosing to spend money to subsidize X, Y, and Z. Yeah. Any other questions? I'm going to move on to the NHS. Yeah.
Hi, I'm Aliza from NCSM, National Cancer Society Malaysia.
Yeah.
I just wanted your opinion on insurance expanding to people with NCDs. Would that be like revenue making, or since you know we've heard that NCDs, people with NCDs, they're actually quite a lot lah.
Yeah.
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 So I just wanted to get your opinion on that.
So it depends on the kind of insurance. Yeah. So there are some insurance companies that are private insurance companies, and they are owned by shareholders, and they are expected to generate a profit. So you can have insurance that may cover non-communicable diseases, but the expenditure from the pool of money that is collected through the insurance premiums has to also generate profits for the shareholders. If you have public health insurance or national health insurance, you don't have that issue of profits having to be generated for shareholders. Yeah, so again, there are different kinds of insurance, and there are also different inefficiencies and efficiencies with the way that insurance systems are run. Some private insurance systems are very inefficient, and they provide coverage at high cost. They often involve a lot of accountants, a lot of administrators to run the insurance schemes, which makes them very inefficient. And the more inefficient they are, the less there is money to cover for the costs of healthcare, to protect patients from the costs of healthcare. So, your coverage becomes less because more money is being spent on administration, or more money is being spent to generate profits for shareholders. So it comes back again to this tension between the interests of different groups in society. Does that answer your question? Okay. What you can cover for non-communicable diseases from insurance also depends on how much money you collect through the insurance system, yeah? If you have a big pool of people in the insurance system, you can collect more money, and through that process, be able to cover more of the health costs of non-communicable diseases. So again, insurance systems come in many different forms, shapes, and sizes. Okay, so I want you to bear all of this in mind when I now recount the story of the NHS, okay? So the NHS was born in 1948, after the Second World War. But when we think about the NHS, it's useful to just imagine what existed before the NHS. So healthcare in the UK before the NHS was very mixed in terms of financing. Financing came from out-of-pocket payments. People would just pay for their healthcare. A large amount of financing came from charitable donations. There were many, many charities in England that provided healthcare for, or paid for the cost of healthcare for people who couldn't afford it themselves. There was a tiny amount of funding provided by local government. And there was also a number of what were called mutual societies or sick clubs. This is where it's like Kongsi, where people come together and they pool their money so that they have their own insurance system, if you like, yeah? And they share the costs with each other. So it was very fragmented, but the role of government was minimal. Yeah, most of it was charity or private payment, out-of-pocket payments. There was some health insurance introduced in 1911, a social health insurance scheme for working men, mainly paid for by the worker, but it only covered the costs of GP healthcare. And it only covered the worker. It didn't even cover the family of the worker. And this was designed to try and make sure that workers kept healthy so that they could keep working. And by 1938, half of the adult working population was covered by this rudimentary social health insurance scheme. In terms of the provider side, most healthcare was provided by private providers. GPs were private. There were mostly private hospitals. Some were charitable, and some were not charitable. And there were a small number of local government hospitals, and these were mostly run as care homes for people with chronic diseases or terminal diseases and for the indigent. They were very rudimentary. Often many of them were hospitals without even hot water or heating. And there was a large amount of charitable service provision provided by the Red Cross, St. John's Ambulance. So again, it was a very mixed bag of services, and there were good hospitals for the rich and very basic poor hospitals for the poor, uneven and unequal. So that's what it was before the Second World War. Then in 1948, the government instituted the National Health Service. The NHS was born. And what was the NHS? How do we describe or define the NHS? So the first, I think, important element of the NHS is the concept of universalism. What do I mean by universalism? I mean the idea was to create one health system for all people. Yeah. Not one system for the rich, or one system for the poor, or one system for the urban areas, one system for the rural areas. Universalism was one health system for everybody. And not just for patients, but also for the health workers. So both patients and health workers were part of a single universal health system. This universal system would be funded through a single pool of public finance. So the financing for this system would come from the government, from the state. So there would be, through this single system, health facilities would become public, and the workforce would become public as well. Yeah. So no more public-private dichotomy. Another principle of the NHS is that it would be free at the point of delivery. Yeah. And built into the legislation that was established to create the NHS was a duty upon the state to provide healthcare. So they said that from now on, government has a duty to provide healthcare to everybody. And the way the health system would be organized, they also set up structures that were based on geographical areas. And that there would be planning on the basis of geographical areas, and that there would be integrated planning so that primary care and hospital care would be integrated into a single system. So what about all of those private and charitable hospitals that existed before the Second World War? What happened to them? This is a picture, a headline from a newspaper in July 1948, talking about the transfer of all of these hospitals to the government. They were effectively nationalized. The state took over the management, ownership, and running of these hospitals. Not all of them, 2,751 out of 3,000 hospitals went into public ownership. How did this happen? Can you imagine this happening in Malaysia today? All of these private hospitals and clinics coming into public ownership. So, I mean, there were a number of reasons why this was possible. It wasn't easy to make this happen, but one thing was that there was a lot of prior social and political mobilization against the inequalities in healthcare in England at the time. And this was aided by the experience of the Second World War. A lot of people died during the Second World War. A lot of poor people died fighting for the country. A lot of working class people died. And after the Second World War, there was a feeling of national unity, and there was post-war unity, and much more of a sentiment about wanting to ensure that everyone had equal access to healthcare. So there was much more solidarity in the country. There was much more political will to ensure that there was a single health system for everybody. The other thing was that during the Second World War, the government, as part of the war effort, had taken control of many hospitals, taken control of the blood transfusion service, the public health laboratory services, because this was in the middle of the war, and they had shown themselves to have been able to manage and deliver these services effectively and efficiently. So the government also had a sense of confidence that they were able to run the health system efficiently and effectively. And then in 1948, also there was a Labour government in place that had been elected on the basis of looking after the interests of the poorer elements of society in England. So all of these things conspired to make it possible for the NHS to be born. But even then, it wasn't easy to make this happen. Who were the biggest opposers to the NHS? It was the doctors. It was the doctors and also the Conservative government. But the biggest opposition came from doctors. And the NHS wasn't born until after the government had had a huge fight with the doctors, a public fight with the doctors. The Secretary of State for Health was described as a complete and uncontrolled dictator, and he in turn accused the British Medical Association of engaging in squalid political conspiracy and organizing sabotage of an act of parliament. It was quite a vicious fight, and it required extremely strong leadership from the government to make the NHS happen. In the end, a deal was brokered. There was some compromise. The doctors were opposed to the idea of losing their autonomy, losing their power within the health system. And as part of the deal, GPs were allowed to run their practices as small businesses, and hospital consultants were allowed to retain their private patients. So they would be working in public hospitals, but they were allowed to also have private practice on the side. And when Bevan was once asked, how did you manage to create the NHS? He said, it wasn't easy. In the end, I had to stuff the mouths of the doctors with gold to make this possible. In the end, it wasn't a large amount of gold, but there was some bribery involved in making sure that the doctors eventually supported the NHS. I want to say that 40 years later, some of the biggest defenders of the NHS have been the doctors. Yeah. So the doctors, after some decades, ended up being some of the biggest supporters and defenders of the NHS. The GPs were allowed to run their practices as independent businesses, but because of the public financing and because of the way in which GPs were contracted, they were independent practitioners running their own businesses, but effectively they were governed, regulated, and managed by the Department of Health. Yeah. So they were independent in name, but they were very much part of a single public system. Yeah. Integrated also with a responsibility for population health and working closely with hospitals. The NHS hospitals, all those hospitals that were taken on by the state became publicly funded, owned and managed. The staff in those hospitals became salaried. Yeah. So the doctors, nurses, their salary, their income didn't depend on how many cases you saw or how many operations you did. You were provided with a salary. The other important element about the NHS isn't just about the bringing it under public management and ownership, but there was a strong emphasis on professionalization. The Royal College of GPs, the Royal College of Physicians and surgeons, etc., were encouraged to develop strong professional standards, professional ethics, and they were given a lot of control to run the health system. Yeah. So the government actually gave the professionals a lot of autonomy and a lot of control over the health system. The General Medical Council regulated the healthcare professionals, the doctors, and similarly, there were other councils for the nurses and allied health professionals. So it was government, publicly funded, publicly owned, publicly managed, but with a lot of autonomy for health professionals. Yeah, and the health professionals, through this autonomy, I think an important part of the NHS was that they took pride in the way that the health system operated. Yeah. So for them, for me, this is a very important ingredient of why the NHS was so effective, because there was pride in the system, and that the pride came from the people working on the front line. Yeah. These are images from the 2012 Olympic Games in London. And I don't know how many of you watched the opening ceremony of the Olympic Games, but there was a big, big section in the opening ceremony where the NHS was celebrated. It was like 30 minutes during the opening ceremony, which was all about promoting the NHS and celebrating the NHS. And I put this in because I think this really symbolizes the pride that people had in the NHS and the love that the Rakyat had for the NHS in England. Yeah. And the pride came from the service being effective, being efficient, but primarily about it being equitable. Yeah. Everyone was treated equitably. And that includes doctors. You could be the best neurosurgeon operating in a teaching hospital in London, but your salary wasn't that much more than a GP working in rural Scotland. Yeah, there was equity for patients, but there was also equity amongst the healthcare workforce. And this, I think, also contributed to the sense of professionalism and the sense of public service in the NHS that made it so effective and efficient. Yeah, so there were always tensions within a health system. Even in the NHS, there were big battles, for example, between obstetricians and midwives. Big, big fights between midwives and obstetricians about how pregnant women should be cared for. And similarly, there have been tensions between GPs and allied health professionals. Yeah. So those things existed, but I would say in general in the NHS, things were relatively equitable. So the turning point came in 1989 when basically the government of that time decided to change the NHS, to change the principles of the NHS. And this was led by the Margaret Thatcher government, and it was accompanied by the ascendancy of neoliberalism. Yeah, you've all heard of the term neoliberalism, is that right? People, who hasn't heard of the term neoliberalism? Okay, I've only got 3 minutes. Q&A. Who's the Q&A? Oh, okay. So I've already had a bit of Q&A. So Chirila sometime. Okay, I want to just define neoliberalism because I think this helps you to understand how it is that health systems have been developing, particularly over the last 3 or 4 decades, including in Malaysia. Okay, so neoliberalism is the dominant public policy paradigm of the last 3 to 4 decades. It's the paradigm that has influenced WHO, it's been influencing the World Bank, it's been influencing governments all across the world. It's been influencing academia. So what are the core tenets of neoliberalism? And neoliberalism is something that doesn't apply just to the health sector, it applies to government and societies in general. So neoliberalism is a policy paradigm which advocates for free markets or advocates for markets on the basis that this is the best way to organize society. And the bigger markets we have, the bigger free markets we have, and the smaller we make governments, the better it is for society, yeah, in very broad general terms. This idea, it comes from this argument that governments are inefficient, governments are corrupt, governments can't be trusted, and therefore it's better to make things marketized and privatized as much as possible. Yeah? And this quote is from Milton Friedman, who's one of the architects of neoliberalism, one of the gurus of neoliberalism, with this quote, which exemplifies the kind of disparaging way in which they view governments and public institutions. It's also based on the assumption that humans are driven to maximize their own benefit. The belief is that humans are fundamentally selfish and that we are constantly striving to improve things for ourselves. And that inequality and social hierarchies are natural and that they are also beneficial. Yeah? So you'll see that a lot of when you look at neoliberal texts, there's this kind of underlying assumption that it is only through inequality that we get innovation, that people strive to do better. And by forcing people to compete with each other, forcing people to strive for their own needs, this is how you advance society. Yeah. Associated with these beliefs and these assumptions is the idea that poverty will be eradicated through economic growth. Yeah? Trickle down, yeah. That it's not through redistribution, but through growth. And that redistribution is unnecessary, but can also be harmful. So this is why you see today the way in which we celebrate billionaires, and we call billionaires wealth creators, as opposed to calling them wealth takers. And because of this idea that economic growth is the way you eradicate poverty, built into neoliberalism is an assumption that you can have perpetual economic growth, that you can constantly grow, even though we live on a finite planet. And because we live on a finite planet, and because we have to have this idea of constant growth, there's a huge emphasis on technology. Technology will be the way in which we can constantly create growth despite being living on a finite planet. So these are the ideas and beliefs of neoliberalism, and they've become very dominant in society, and particularly dominant in institutions with power. I think if you ask most people in most countries, they won't agree with these beliefs and assumptions. But nonetheless, these beliefs and ideas have resulted in a number of policies that have become very dominant. If you believe that free markets are the best way for organizing society, and you believe that governments are best when they are small, then the policies you are going to promote would be deregulation, low taxes, and increasing privatization, commodification, marketization. In order for markets to work, supply and demand to work, you don't want public ownership, you don't want public property, you want it all to be privatized, yeah? So that you can sell and buy on the market. And so you also see an association with strong private property rights, yeah, attached to neoliberal policy paradigms. And as I said earlier, there's this emphasis on technology and productivity. Okay. I'm being very general here about neoliberalism. And when neoliberalism does talk about the state and about government, it talks about small government, but there's important functions of government. One is to protect property rights, the other is to maintain law and order, and the third is to have a safety net for the poor. So these are often described as the key core functions of the state. But you can see from this that neoliberalism is incompatible with the NHS. Yeah? The NHS was completely different. The NHS said, let's expand the role of the state. Let's make the public bigger, not smaller. And let's bring the entire health system into public management, public ownership. So when neoliberalism became dominant in the 1980s, 1990s, that was the start of the erosion of the NHS. Okay, I'm just going to... And basically what we've seen in England has been two things. One is the application of these neoliberal policies and assumptions to the NHS. The second important thing is that we also saw a deregulation of the financial sector. Yeah. So neoliberalism impacted on the health sector, it impacted on the manufacturing sector, impacted on agriculture, education. It impacted also on the financial sector. And the financial sector became deregulated. One of the consequences of the deregulation of the financial sector has been a growth in the amount of private finance capital. Okay? Now, in the last 3 or 4 decades, if you look at the total amount of private wealth and you look at the total amount of public wealth, the graphs look like this. The total amount of public wealth has been declining slightly. The total amount of private wealth has gone up. This is across the world, but it's the same thing happening in many countries. A lot of that private wealth is also highly concentrated. So you all know about how 20 people own as much wealth as the bottom 50% of the world. We all know about Elon Musk soon becoming the world's first trillionaire. There's a large amount of concentrated private wealth. This private capital is looking for places to invest in. Okay? This is private capital, and private capital wants to invest and make even more money, make more returns. This private capital is very powerful. And this private capital over the last 2 or 3 decades has been looking at countries like the UK and saying, we want to be able to invest in the health system in the UK in order to be able to create business opportunities within the NHS, within the health system of the UK. Because up till then, the UK health system was publicly owned, publicly managed, publicly funded. It wasn't to generate profit, it was to generate good health. This private finance capital, very powerful, has been able to lobby politicians and governments in order to open up the NHS to investment. Okay? This is the big picture. And as a result, from the 1980s till today, the NHS has been slowly and gradually chipped away. The public sector has been shrunk. The public sector has been underfunded in order to create room for private investment, to create opportunities for investment in hospitals, primary care services, diagnostic services, radiology services. So that's what's been happening over the last 3 or 4 decades. And so what we have today in the UK, it's still called the NHS, the label is still there, but the system itself is no longer there. There is a public system, there's a private system, there's a large amount of public money now flowing into the private sector. The private sector is owned by shareholders, and these are shareholders who are now generating large profits in ways that are then undermining the functioning of the health system as a whole. So in the health system in the UK now, you see growing inequalities, growing demoralization, growing demotivation, doctors going on strike, nurses going on strike, waiting lists going up. This is because the system itself has become increasingly dysfunctional. So that's the rather sad story of the NHS. But I don't know what exactly are the relevance, what is the relevance of this story to Malaysia. But I hope it gives you an idea of how to think about the way health systems are funded, organized, managed, and to always have this political lens when you analyze health systems and health systems policy. Yeah, there are competing ideologies. The NHS was built on an ideology which was more socialist, more based on solidarity. What we have with neoliberalism is an ideology that is based on the market, on competition, on a small role for the government, and on a tolerance and acceptance for inequalities. Okay, so let me pause there and see if there are any comments or questions.
Sorry, quick one.
Yeah. I can say.
Okay.
Yeah.
Hypothetically, thanks for showing the start, the beginning, and the demise of NHS, which is quite close to my heart, just like yourself, right? And I witnessed that. So hypothetically, if there wasn't any capital market investors coming in and having this neoliberalism thing, right, where will NHS stand today?
Yeah. So even with the NHS, if you think about the pharmaceutical sector, you think about the technology, the building of hospitals, the production, manufacture of equipment, all of that was in the private sector. So the NHS had a private sector, and it was reliant also on a kind of capitalistic sector in terms of pharmaceuticals and technology and equipment. And this is a big question, is how do you get the balance right between markets and a private sector based on the principles of capitalism with the principles of the NHS, which are talking about people having rights, governments having duties and responsibilities to their rakyat, and wanting something within society that is founded on the principle of equity and social justice. So how you get that balance right is a question that society has been asking itself for centuries. I think there are reasons why the healthcare sector should not be open to markets, should not be open to commercialization and profiteering. But I don't say that about the fashion industry or about the automobile industry, but I do say that about health and healthcare. Maybe I would say that about education as well. But this is my view, this is my ideology, and other people may have different views and ideologies. This is an ideological issue, it's not technical.
Okay, if I may shift the counter position back a little bit to NHS and Malaysia, KKM specifically. The reason this comparison is of special interest to us because our health ministry, okay, is essentially an institutional variant, okay, of the NHS, right? Yeah, with the difference that all our healthcare staff in KKM are salaried. Mm-hmm. Yeah, medical officers, nurses, paramedics, specialists. Yeah, but we are essentially a variant, okay, of NHS. Okay, so so I was especially keen to have you speak, okay, given your experience straddling both systems, okay, what lessons we could learn from what happened to the NHS, and perhaps what we should avoid again in the case of KKM. But I think there's one area in which there isn't that much overlap, which is more specific to the Malaysian healthcare ecosystem, okay? And that is the role of the state as an investor. Okay? Yeah, I don't think in the case of the UK, okay, the state itself, okay, is that heavily invested, okay, in for-profit healthcare. Okay, I mentioned in my earlier presentation, yeah, that it didn't start out. They didn't start out intending to be a major investor in commercial healthcare. Okay, but it had to do with one of the major hospital chains, Pantai, okay, on the verge of being taken over by Singapore-based interests. The Sovereign Wealth Fund stepped in to retain what was considered then a strategic national asset. Okay. But things evolved from there, and it ended up being this huge institutional public sector investor in commercial healthcare. So, what are your thoughts on what, for people like us who are concerned about maintaining equitable access to healthcare under whatever institutional mix? Okay, what are your thoughts on what might be the best way, okay, to try to defend, okay, equitable access to healthcare on the basis of need? Okay, that situation in Malaysia.
So yeah, Malaysia is very interesting. It's very unique in that the big private hospital chains, there's a large amount of those private hospitals are owned by the state. And maybe the first thing I want to say is that when we talk about private hospitals, they are not all the same. Yeah, you know, the way private hospitals are run can vary hugely. I know I worked in Africa for many years. There were a lot of private hospitals that were run by religious organizations, and they were private, but they were not run for profit, and they provided very good health care, and they contributed to equity. A private hospital owned by government could, in theory, be run very differently from a private hospital owned by a hedge fund, or owned by a bank, or owned by BlackRock. Yeah? A private hospital run by a government could be run in a way that contributes to the entire national health system, rather than being run purely to generate revenue and income for that one hospital. Is it being run to support the health system as a whole, or is it just being run as a business, with the government acting like a shareholder, acting like BlackRock? We want to maximize our profit. We want to maximize our return. I'm doing some research in India and Kenya, looking at different private hospitals. There are many private hospitals. Many of them are still run and owned by the doctors themselves. They built the hospital, they run the hospital as a private hospital. Increasingly, these hospitals are being bought by big transnational corporations. And once they're bought by these transnational corporations, the way they operate changes. They become very aggressive in terms of extracting profits. So, you know, I think Malaysia is where it is now, with a big private sector, but it has an opportunity because of the ownership structure for the government to regulate and shape the private sector so it contributes to the public sector, as opposed to the private sector in many ways undermining the public sector. That's I think what is happening now. It's causing problems for the public sector, but it needn't be that way because of the ownership structure, which is so unique.
Yeah, a while back, some years back, when One Care, the predecessor of SHI, was still in play, I asked Dr. Rosita Hussein, who was the prime mover of One Care at that time, when that thing was still under consideration, whether the envisaged panel of providers, in that SHI scheme, whether it would include, the government-owned commercial hospitals, with the assumption that the fee schedule, for reimbursement to the providers cannot be overly generous, otherwise the fund will go bankrupt. So it will be reasonably modest. So I was curious to know whether the publicly owned commercial hospitals would be required or whether they will be allowed to opt out again of that to serve again niche markets like medical tourists, affluent Malaysian patients. I didn't really get an answer again. So I guess the answer to your question is still a big question mark. The other comment I'd just like to make is that one of the major investors in India again, okay, the controlling stakeholder of the second largest hospital chain in India, Fortis, okay, is actually IHH, isn't it? So our quote unquote public equity investors again are heavily invested in China, in India.
I think it seems to me that one crucial difference between private and public hospitals is the system of remuneration of specialists. Because in the public hospital, of course, everyone is salaried in a way. In the private hospitals, each specialist operates independently as an independent operator. You know, they register their own company and they contract with the hospital. So which brings up the question, of course, in an SHI system, for instance, how is this, when they talk about integration of public and private sectors, how is it going to affect the payment systems of specialists in this system and in this system? Will all private sector specialists then be salaried, or you know, like if you say that for example that these GLC hospitals could theoretically be made to be more amenable to supporting the public sector, how will they navigate this relationship with the specialists?
So there are many ways in which you can remunerate a specialist in a private hospital. You can salary them. They can be salaried. They can have salary plus benefits or salary plus additional income that may be generated through activity-based metrics. So, I mean, there are different ways in which you can organize the way in which doctors are paid for.
Sort of like nationalizing the specialists.
Yeah. I mean, again, this is all about how you regulate and manage the private hospital. But, you know, in many of the hospitals that I've been looking at in Africa and India, for example, a lot of the doctors are salaried and they have a very low salary, and their salary is also adjusted according to how many procedures they do. So they're incentivized to do as many procedures as possible. And this has resulted in other problems, you know. Women being given hysterectomies when they don't need a hysterectomy, overdiagnosis, overtreatment. So how you incentivize and pay doctors and other health workers is really important. What I will say about my experience in the NHS is that most doctors, health workers were well paid, were given a decent wage, but they also receive many non-financial benefits. And this is what kept them going and kept them motivated. Non-financial benefits, including educational opportunities, career development opportunities, but also the benefits of feeling good, of pride of working in the NHS. And I think that goes a long way. It's often it's undervalued as a driver of healthcare behavior, healthcare provider behavior. You know, doctors and nurses were looked up to in England if you're part of the NHS, and you derived a lot of benefit from that. Yeah.
Okay, very quick one. We're talking a lot about money, but this is about healthcare. That's a human right, right? And when you're talking about you're giving your examples there, and Prof. Chan earlier, there's this huge disparity because we're talking about specialists, the amount of money the specialists make, the amount of money hospital makes, and then at the same time, we're talking about the fact that nurses are not paid enough, allied health is not paid enough. So you're looking at healthcare as a whole, as a human right. Where do you think Malaysia is going to go? What should we do to not become, as drastic as the NHS or something like that? How do we find that balance?
Yeah, ultimately it requires political leaders to shape the health system. And those political leaders are going to be motivated either to serve everyone in society, or they're going to be motivated to serve only some people. But there's no academic or technical answer to that question. I mean, this is a political issue, and I think this is why the history of the NHS is important. It happened after the Second World War because the social political environment allowed it to happen. And you see 40 years later, it was undermined and it reversed. But, I think Malaysia should take pride in the first 4 or 5 decades after independence. It did amazing things in terms of improving health. And somehow it's the same thing as what happened to the UK happened in Malaysia. We allowed a different mentality, a different policy paradigm to come into the health sector. And we're now in this mess of a mix between public and private and for-profit and non-profit, and all of the growing inequities and dysfunctionalities that come with it. Yeah. How you reverse that? It will require social mobilization and political leadership. Yeah.